Protocol 50 is our tachycardia pediatric protocol. Okay, first question we need to ask is the patient hemodynamically stable? If the answer is yes, and the QRS duration is wide or greater than 0.09 seconds, we want to evaluate the patient with a 12-lead ECG. If probable VTAC, we need to consider adenosine at 0.1 milligrams per kilogram IV-IO, max dose of 6 milligrams, and prepare for synchronized cardioversion. Consider Versed for sedation at 0.02 milligrams per kilogram IV-IO or IN to a max dose of 2 milligrams. Synchronize cardiovert the patient at 0.5 joules per kilogram, and you may repeat at 2 joules per kilogram. Amiodarone, 5 milligrams per kilogram IV-IO should be considered, and that's given over 20 minutes. Max dose of 150 milligrams, and you can repeat that one time if needed. Okay, so for our hemodynamically stable patients with a QRS duration that is narrow or is less than 0.09 seconds, we want to evaluate with a 12-lead ECG, and if the rhythm is a probable sinus tachycardia, which means the infant's heart rate is less than 220 and the child's heart rate is less than 180 beats a minute, then we want to identify threats and underlying causes and exit to appropriate protocol. Now, if it is probable supraventricular tachycardia, infant's heart rate greater than 220, children's heart rate greater than 180, we want to attempt vagal maneuvers and administer adenosine at 0.1 milligrams per kilogram IV or IO, max of 6 milligrams, and we may repeat that at 0.2 milligrams per kilogram IV-IO, max of 12 milligrams. Now, if we have no improvement after adenosine, we want to go straight to synchronized cardioversion. And if we have time, we can consider Versed at 0.02 milligrams per kilogram to sedate the patient, IV-IO or IN, to a max dose of 2 milligrams. And our synchronized cardioversion doses are 0.5 to 1 joule per kilogram, and we may repeat at 2 joules per kilogram. Okay, so for our pediatric tachycardia patients who are hemodynamically unstable, we are going to consider midazolam, if time permits, for sedation. 0.02 milligrams per kilogram, IV-IO or IN, max dose of 2 milligrams. We are going to synchronize cardiovert our patient at 0.5 joules per kilogram, and you may repeat at 2 joules per kilogram. And also, we're going to consider amiodarone at 5 milligrams per kilogram IV-IO over 20 minutes. Maximum dose is 150 milligrams, and you may repeat this one time if needed. Okay, Protocol 51 is our ventricular assist device protocol, and this can be a left ventricular assist device or a right ventricular assist device. When we're doing an assessment on a patient with a VAD, we need to auscultate at the left sternal border to the upper abdominal quadrant. If we hear a continuous humming, then this means that the VAD is working properly. The pump is working. Also, when the pump is working, you will not have any palpable pulses, no measurable blood pressure, and no pulse oximetry readings. So you need to rely heavily on your clinical assessment of perfusion. Skin color and temperature, cap refill, mental status. If we do have signs of obvious death, we need to withhold chest compressions. So we need to determine whether or not our patient is stable or unstable. If they are stable, we're going to treat per appropriate protocol. However, if our patient is unstable, we need to consider that this may be another general medical problem, such as hypoglycemia, and treat appropriately. Also, we need to look for volume depletion and give rapid normal saline fluid boluses. Check an EKG for abnormal cardiac arrhythmias and treat appropriately. And also the controller alarming. Is the controller sounding an alarm? We need to treat for cardiogenic shock and change controller if instructed. Okay, so for the ventricular assist devices, we always contact the VAD implant center. We allow the patient's trained companion to stay with the patient, and we transport all of the VAD equipment with the patient. Now here's your VAD-capable EDs. Inova Fairfax Hospital, MedStar Washington Hospital Center, University of Virginia Medical Center, and the University of Maryland Medical Center. Okay, so again, for Protocol 51, become very familiar with the ventricular assist device protocol. Information on VADs can help you with troubleshooting procedures. At the left there is a picture of a patient that is wearing a ventricular assist device. Protocol 52 is your OBGYN childbirth, labor, and delivery protocol, and we have no change in our current protocols in the treatment of your pregnant patients. In this protocol, there is also a picture of the knee to chest position for the prolapse cord, shoulder dystocia, limb presentation, pregnant female, as well as an APGAR score. Protocol 53 is our OBGYN pregnancy-related emergencies protocol. Okay, so protocol 53, there's a few questions we need to ask. Is our patient actively seizing? If our pregnant patient is seizing, we're going to administer mag sulfate at 4 to 6 grams IV-IO over 5 minutes, and follow that with midazolam or Versed at 5 milligrams IV-IM-IO. Repeat every 2 to 5 minutes as needed to a max dose of 10 milligrams. Also, we need to obtain an ECG. Now, if our patient is not seizing but is hypertensive, preeclampsia is defined as a systolic blood pressure greater than 140 and a diastolic blood pressure greater than 90. We need to consult medical direction before administering mag sulfate. For our advanced through paramedic providers, for a hypotensive pregnant patient, we need to ensure that the patient is lying in the left lateral position. And if they are and they still are hypotensive, we will administer normal saline boluses at 500 milliliters IV-IO to maintain a systolic blood pressure greater than 90 millimeters of mercury to a max of 2 liters. If no improvement, we're going to exit to the hypotension and shock protocol and treat appropriately. Now, for all provider levels, labor, we're going to exit to childbirth, labor, and delivery. Okay, protocol 54 is our WMD ChemPack protocol, or our weapons of mass destruction protocol. Now, this protocol is designed for organophosphate poisoning or nerve agents. In this protocol, the symptom severity of minor or major, that is, minor symptoms of respiratory distress and sludgem, salivation, lacrimation, urination, defecation, diarrhea, GI upset, emesis, and muscle twitching, and major symptoms, altered mental status, seizure, respiratory distress, or respiratory arrest, we are going to administer the Duodope kit, which we're going to talk about in the skills portion of this training. But the two medications that are contained in the Duodope kit are atropine and prolixidine. For the minor symptoms, we're going to administer atropine at 2 milligrams IV-IO or IM every 5 minutes. The pediatric dose is 0.05 to 0.1 milligrams per kilogram until the symptoms resolve. And we're also going to give the prolixidine, or the 2-PAM, at 600 milligrams IV-IO or IM, and the pediatric dose is 25 to 50 milligrams per kilogram. Now, for the major symptoms, we're going to administer atropine 6 milligrams IV-IO IM every 5 minutes. Pediatric dose of 0.05 to 0.1 milligrams per kilogram until symptoms resolve. And we're also going to administer the prolixidine or 2-PAM at 1,800 milligrams IV-IO IM and the pediatric dose of 25 to 50 milligrams per kilogram.